So the last objective here today is really going to be talking about what do you do. Okay, so I'm a cyclist. I put this on there, but this is probably not the best way to raise T. I want to think that it is because I really enjoy it. But if you want to raise T, you need to do HIIT therapy, high intensity interval training, which means you can do this and you can climb a hill and go really hard for a minute and then recover for 2 minutes and then go really hard for, that kind of a thing. And you can do it on a bike, you can do it on a rowing machine. I saw a lot of you down there this morning exhibiting wonderful form with HIIT therapy on the various devices of torture. You can do this naturally. Let's talk about what production looks like without testosterone. We go into this whole PTSD mnemonic with you guys because not to induce PTSD, but to give you something for Monday morning. Just remember that transport and conversion for the T, sensitivity is going to be a lot really about how do we bump up androgen receptor density, and detoxing is going to be about aromatase and 5-alpha reduction. So production, it's really about cardiometabolic stuff. It's weight loss. It's treating that metabolic syndrome person. What would you do? You'd talk to him about food, movement. You might talk to him about stress management and sleep. After this week, you will. You'll add those two. Even the traditional doctors know about movement and weight loss, though. So, what about production? Okay, weight loss is associated with less testosterone deficiency. Exercise improves it. We've got nutritional support with micros and macros, and sleep and stress management, huge in increasing the production of T. Getting rid of some of the toxicants and optimizing antioxidant enzyme systems is a big deal, and we'll get into that in a minute. As far as transport, it's really, as far as my talk, it's about the role of SHBG and how to modulate it for increased levels of bioavailable T. A little different than Joel's talk, where women that have PCOS, women that have problems with breast cancer risk, endometriosis, where there's estrogen dominance, we're kind of wanting to optimize SHBG so we've got less free estrogen doing all those bad things. Well, it's a little bit reverse of that with the men's talk because we want less SHBG when it comes to thinking about this from an academic point of view to have more bioavailable T. Now, that's not to be confused with the studies you'll read that correlate low T and low SHBG levels with more metabolic syndrome. The takeaway is that by using nettle and some of the things we're going to talk about that optimize the bioavailability of T by lowering SHBG, you're not going to promote metabolic syndrome. Those are two very different statements. So, what about that? We're going to move then from T now to sensitivity. We're going to get into what increases sensitivity at the androgen receptor, and we're going to talk about aromatase and 5-alpha reductase in the context of detox. The D in the PTSD for testosterone is a lot about metabolism of T downstream to estrogen or T downstream to DHT, just to make that easier to get your head around. So we said that we could produce more T by losing weight. Well, here's some data. Basically, this study looked at a meta-analysis where there was body weight loss reversing obesity-associated low T. And what they found was that whether you did it with a medical-assisted diet with caloric manipulation or whether you did it with surgery, bariatric surgery, they both worked. The bariatric surgery worked best. Those who lost more weight had more T production. They were the younger ones who lost weight had more T production, and it tended to be more profound effect if they were non-diabetic and started out more obese. The key takeaway here is that the degree of body weight loss was what determined the total T bump. It also was associated with less estrogen as they lost weight. So you kind of get a twofer. Leaving for a moment the weight issue related to bumping T au naturel, what about metabolic syndrome and insulin resistance? This is a study looking, it's a year long, at either comprehensive diet and exercise alone or comprehensive diet and exercise plus a transdermal T patch. And these were guys with prediabetes and diabetes. And at the end of the year, what they showed was that both groups improved with markers of things like A1C, glucose, HDL, and T, but there was an 81% reversal versus only a 31% reversal in metabolic syndrome in the lifestyle people who also took a testosterone replacement patch. These were people that were low in T. It wasn't just like someone walked in and said, slap a T patch on me. So there was a clear advantage above and beyond just simple lifestyle for the reversal of that. 50% difference. I thought that was amazing. European male aging study, greater than 15% loss on BMI was associated with significant improvement with not just total T, but free T and LH. So it's working, it appears, at the central axis. And this has been supported by lots of other studies. And it appears to occur despite how the person loses weight. It's the weight loss that makes the T go up. Take-home message. Exercise. This is a paper in 90 Asian guys that had a caloric restriction as well, dietary manipulation. But the bottom line is what they were manipulating is the volume of exercise. 150 minutes a week versus 200 minutes a week. And lo and behold, the guys that did 200 minutes a week had better T, better metabolic and body composition numbers, including sexual function, over the guys that exercised just 50 minutes less per week. And we know exercise bumps T, not just any exercise. Boy, if there's anything I could leave you with today, it's not the triathletes, and I was one necessarily. It's not the ultra runners. It is not the people slogging away at 220 minus their age times 75%, the old aerobic calculation zone, for an hour on the treadmill with the incline at 4%. Those people are making a lot of oxidative stress. They're not necessarily making a lot of T. It's the strength training and it's the cardiovascular training that's done right with high-intensity interval training at a shorter distance. Less oxidative stress, more growth hormone, fitness levels go up much quicker. This is a study showing how heavy resistance training in older and younger men worked. Same thing here. This study showing that free T goes up with younger men and older guys who do strength training. So my family, I come from a family, my dad was a two-time world champion Olympic distance triathlete in 2015 and 16. And a year ago, I sat there while he was on the podium and watched his mouth drop, and he's slurring his words. And yeah, he's having a TIA right in front of me while he's signing autographs, having just won a regional championship. His Kaiser doctors did all the typical stuff. He had a small frontal lesion. He had a small stroke on MRI. And when it all came down, and all the labs were normal, this guy has no risk factors for CVA at all. None. Without clothes on, he looks better than I do. The guy's ripped. He's 78 now. Anyway, so I do my inflammatory panel on him. I start looking at CIMTs on him. He's jacked. Here's a guy who does everything right, and he's got all these markers of inflammation, and yet his cholesterol, his blood pressure, his blood sugar are perfect. Escaped all the Kaiser neurologic workup. And so long story short, we did some things with him. We turned all those things green from red, and we'll see how things go. But he's 78, he survived that. But my own personal experience has moved me towards this type of right exercise as opposed to just doing too much of a bad thing. And I think it is bad when there's excessive cardiovascular training 2-3 hours a day. And there's some good data to support that too, on kidneys and cardiac function. The micronutrients are important. Androgen deficiency, I talked about PADAM, which is just another acronym for androgen deficiency, is often helped when you've got micronutrients. We know there's studies showing A, D3, zinc, selenium are favorable, not to just androgen production, but also to sperm production. These poor chickens, I've talked about these chickens for about 6 years, I think now, Dan, but we have a nice, pretty graphic. This one's got a soccer ball. Thank you, Kayla. Somebody did this beautiful graphic. It renews my enthusiasm. Bottom line, in men who have been exposed to cadmium, which if you start doing heavy metal testing, this is a really big problem in a lot of people. Come to find out that their testicular tissue levels of antioxidant enzyme systems, SOD and glutathione peroxidase that you learned about this week, are hampered. And in fact, the selenium levels there in the tissue tend to be low, and it's correlated with low serum T. Come to find out, if you give these same chickens in this paper, if you pre-treat them with selenium, they act, which is an antioxidant, it supports glutathione peroxidase in particular. It tends to ameliorate some of the toxic testicular side effects that occur when they're exposed to cadmium. So, if you have good antioxidant support, you can really help with T. We know T is important with making sperm, not just vitamin A. You need both to make this whole seminiferous epithelium get going and cause the spermatic wave of spermatozoa maturation. T is a very big part of that. Zinc is important. We know that there's the effectiveness of zinc in treating men's infertility. In this paper is a big deal. You can reverse a lot of the low T associated infertility by supplementing. This was just 6 weeks with zinc. It wasn't a big dose, 60 milligrams for a short period of time. And you saw increases in not only T, but big increases in sperm count. D, you guys, after this week, you could lecture me on this. I mean, it's a big deal. This is a study showing that if you had 3,000 units a day versus placebo for a year, you increased the amount of total bioavailable and free T as opposed to those that weren't supplemented. And there's several studies on D that you can look at, all saying the same thing. So as far as transport, we know that there's this issue with sex hormone binding globulin. This is something, I believe it's in your toolkit now, where you can just look and know, hey, what increases it and what decreases it? For the male side of thing, we're kind of looking at things like stinging nettle, protein, adequate diet to have an SHBG that's not through the roof so that you can read your total T's at face value. And they've got optimization of their bioavailable T. There it is in the toolbox. Bringing some of this point home, why knowing this is important. This is a study showing that guys that had like a vegetarian or low protein diet actually had higher levels of SHBG and had lower bioavailable levels of T because of it. On the other side of that, if you've got adequate omega-3s, this paper showed that it was associated with a decrease in SHBG, and the assumption is that then you're going to have more bioavailability as well. Sensitivity is interesting because it's really all about exercise, which I kind of droned on about the resistance already. Basically, within 3 hours of starting a resistance exercise training, what you will see is a 40% increase in the density of androgen receptors if you look at a muscle biopsy. Pretty amazing, within 3 hours. So those of us that were in the gym lifting this morning, or that were doing that, by mid-morning, you had a 40% bump potentially. And it lasts for a couple of weeks in this paper. Not only that, they got a 16% bump in testosterone levels. So detox is really just about these two downstream pathways involving aromatase and 5-alpha reductase. Cadmium is more of a detox issue that we talked about with selenium. It's important to know that things like hyperinsulinism and having excess leptin, which is what you see with increased central obesity, having problems with stress, being older, having inflammation, affect and upregulate these two enzymes, 5-alpha reductase and aromatase. And so there's this commonality that you find with bad environmental things making your T go away through both metabolic or detox pathways. Here it is, and this is really what you've seen already this week, or this morning. As far as aromatase inhibition, this is something we're after. We don't want to kill aromatase because guys rely on some estrogen to have normal bone density. I worry about the guys that come in on testosterone who are on high doses or even inappropriate doses of anastrozole, which is an aromatase inhibitor prescription. And I do a DEXA, and they're all osteoporotic. A lot of them are being overdosed, and no one's following those things. So it's important to know what can modulate aromatase. This is basically a list of botanicals. I find that these are have less impact than fixing glucose, fixing inflammation, and fixing hyperinsulinemia. But they're there, and they're in your toolbox. 5-alpha reductase inhibitors are also there in your toolbox. The red ones mean that they made both lists. And so if you want to find botanicals that give you the biggest bang for the buck as far as inhibition of the downstream loss of T, those are in red. Both in your toolbox. This is a study just showing how basically the guys in this study that had increased soy isoflavones had lower levels of estradiol, and they determined that it could possibly be due to the aromatase inhibition that we know happens with flax lignans and with things like soy isoflavones. These are some of the things you're looking at: optimizing SHBG, getting as much free T as you can, modulating aromatase by treating things like hyperinsulinemia, obesity, stress, and too much leptin and insulin. Same thing with 5-alpha. And then testing. The test, don't guess is a really good acronym. So going over what we've just said, let's kind of pick this apart a little bit. What is TD? It's kind of this new term relatively proposed by these experts. It's supposed to more accurately reflect what's really going on. Know that TD is not just a biochemical phenomenon, but it's got to be connected to both a history physical with signs and symptoms. Know that there's these groups that are really prevalent with low T, such as obese patients, diabetics, those with opiates, dyslipidemic, and even your hypertensives. While T levels go down by decade, know that that's not the most strong statistical predictor. It's the comorbidities, and that most of the people that do have an age-related T deficiency, it's because of that very small minority with primary TD. People you're going to see are largely going to be in that other group. Remember that there's these associations, and they have impacts on our physiology. So when people show up with these seemingly unrelated conditions, think again. As far as lab, serum's the least expensive. It's my workhorse. Dried urine adds the metabolites. Both urine and serum correlate best with clinical symptoms like hot flashes, body comp changes, and bone density. Saliva is a little bit less supported, and it can overestimate, especially when you're doing topical applications. I don't use it for that reason. It's a little less consistent, and it doesn't correlate like the urine and the serum do with clinical evidence that your body's seeing the hormone. Hot flashes going away, body comp improvement, bone density, and the brain seeing it with LH suppression. So remember that PTSD is your roadmap to finding the comorbid problems that more often than not give you clues to how to avoid TRT. And TRT is a whole bag in and of itself. It can be done well. There's ways to raise T with prescription medications other than testosterone for maintaining fertility. For that, there are other ducks, which I hope to see you next July for. All right. Thank you.